clearly we've made dramatic strides in the way we can treat our patients with advanced melanoma. And what's been very incredibly encouraging to see is the rapid advances and actually the changes in the standard of care that has occurred in how we treat our patients frontline with metastatic melanoma. And in 2011, with the approval of ipilimumab and vemurafenib, that really began kind of this cascade of new therapies. And that actually also began our ability to think of how we treat patients based on different molecular profiles. And that's really when we began to treat, or consider treating, our BRAF mutant melanoma patient population different from the wild types. And then, quickly after that, with the approval of the PD-1 inhibitors, and subsequently the efficacy with combination ipilimumab, PD-1, BRAF, MEK, and so forth. But the topic that I was given today was, well, what do we do after we've done all of that? And actually, the way I interpreted that question was, what can we do, short of doing a clinical trial, which is, I think, kind of the right answer. And so, what I'm doing today is talking a little bit about kind of, what the historical, or what are now quote-unquote historical treatments that we have available that we can go back to. I think we can't forget that. We are able to cure patients with high-dose IL-2, that there still may be a role for cytotoxic chemotherapy or biochemotherapy. And so these are things that I think remain in our armamentarium, despite the fact that we don't use them very much. And as we think about revisiting some of these older agents, we have to think about how mechanistically can these drugs be matched up with our newer agents? For instance, it's very clear that cytotoxic chemotherapy affects not just the tumor cells, we're not just killing the tumor cells, but we're affecting the biology of distinct subsets of the immune system. And so, for instance, in addition to just causing an immunologic cell death, with some of these cytotoxic agents, we can increase antigen presentation. We can increase co-stimulatory molecule expression on the tumor cells, on the immune system. We can decrease expression of some of the checkpoint molecules. And so there may be a smart way to actually incorporate some of these older agents.